Hi, I'm Laika. Welcome to our Review Academy. Today we'll be talking about pediatric nursing, cardiovascular disorders, particularly the Tetralogy of Fallot. So let us first define what the Tetralogy of Fallot is. This is actually a congenital heart defect, meaning at birth it is already present for people who are afflicted with this disease. It is a cyanotic heart defect, meaning that because of these defects that the patient has, it will lead to a bluish tinge in the patient's extremities. These patients are called blue. Okay, let's write that in blue so that it's easy to remember. Blue babies. And that is because there is there's a huge decrease in the oxygenation of the patient's blood, which leads to this bluish tinge, this cyanosis. All right? So from the word tetralogy of Fallot, tetra, meaning there are 4 structural defects that are present and that can be appreciated in this disease. First, there is what we call pulmonary stenosis. Number 2, there is what we call a right ventricular hypertrophy. Number 3, there is what we call a ventricular septal defect, or a VSD. And last but not the least, there is what we call overriding of aorta. So let's first, so that's again pulmonary stenosis, right ventricular hypertrophy, ventricular septal defect, and overriding of the aorta. Is that understood? All right, let's move on to, but let's go dive into this later in the pathophysiology. Let's first take a look so that we'll understand the pathophysiology, the normal circulation that occurs in the heart. Okay? So first, all the blood enters. So we have 2 circulations, the right side of the heart and the left side of the heart. The goal of the right side of the heart is to push blood into the lungs for it to be oxygenated, and the goal of the left side of the heart is to push that oxygenated blood into and deliver it to the rest of the body. Now let's trace that. So from the superior vena cava, it enters, and the inferior vena cava into the right atrium. Okay, into the right ventricle, pushed into our pulmonary arteries. Okay, that deliver that blood into our lungs. Now, that kind of blood gets oxygenated. We're in the left side of the heart now. The left circulation. Sorry. All right. That enters here into the left ventricle and then into our aorta, where it is delivered to the rest of the body. But this is not what occurs in Tetralogy of Fallot, again, because there are 4 different structural defects that affect its circulation. First, let us trace that again as we normally would. So again, into the superior and inferior vena cava, the oxygenated blood enters to your right atrium and then to your right ventricles. And normally, it goes over here to our pulmonary arteries. But take a look over here. This is our pulmonary artery. Correct? This is our pulmonary artery. What happens and what occurs is, if you can see this, there is a stenosis, a narrowing in our pulmonary artery. So what do you think happens to the blood that's supposed to pass through here? It will have a difficult time, right? Passing. Okay, so most of that blood goes back. Okay, most of that blood, instead of passing through, it backflows, right, into our left ventricle. So now you have a lot of blood, a lot of deoxygenated blood over here in your right ventricle. Do you understand that? So that is our first problem. Our first problem, this is our pulmonary stenosis, the narrowing of our pulmonary artery. Now let's move on to let's continue. Right, so it's supposed to go to the rest of the body, but it has a difficult time because there is this particular, okay, there's this stenosis. So our heart, okay, our muscle here, the muscle over here has to push extra hard. Has to push extra hard to get that blood delivered through that narrowing. And that is what we call, okay? And so through time, if this keeps happening chronically, what happens to this part of our heart? It becomes enlarged, because if you keep using that muscle, again, our heart is a muscle, if you keep using that muscle, it will eventually enlarge. And that is what you call your right, okay, the ventricle, ventricular hypertrophy. Did you understand that? All right. So now let's continue. So let's say the right ventricle is successful enough in pushing some of that blood into our pulmonary artery, but very little, not normal, right? Because again, there was a stenosis, there was a narrowing. So delivers it to the lungs, whatever blood passes through, whatever little blood passes through, and that reoxygenated blood is delivered through our pulmonary veins and into our left atrium. Now, from our left atrium, it goes into our left ventricle. All right. So you have some blood here that is oxygenated. Am I correct? Yes. But let me ask you this question. Take a look at this. Which side, which ventricle do you think exerts more effort and therefore has higher pressure? Is it the right side of the heart, where there is a stenosis and there is a lot of blood pooling here? Or is it the left ventricle, which receives just little blood? Which side exerts more effort and which side has higher pressure? Of course, the pressure on the right side of the heart is higher. All right? So, therefore, which do you think is the direction of the shunting? Is it going to be right ventricle to left ventricle, or from the left ventricle to the right ventricle? Of course, it is our right ventricle to left ventricle. So the blood, this deoxygenated blood in our right ventricle, is then transferred through that septal defect into our left ventricle. That mixes with the oxygenated blood and is therefore, okay, there's mixing of blood, which is why we represent it as color purple. All right. Now there's mixing of blood. We need to deliver this mixed blood. Okay. Where does the left ventricle push? To the aorta. Right? To the aorta, which delivers that mixed blood. Not very little oxygenated blood and a lot of deoxygenated blood to the rest of the body. Now, do you understand now? It's purple. Do you understand now why the patients are cyanotic? Because there's not enough oxygenated blood being delivered to the rest of the body. So this again is our first problem, pulmonary stenosis. Our second problem over here, the right ventricular hypertrophy. Our third problem is this one, the ventricular septal defect. And number 4, the overriding of the aorta. The aorta is not supposed to be delivering the mixed blood. Okay. Do you understand? Okay. Now let's move on to our signs and symptoms. So, the pathognomonic sign and symptom is what we call TET spells. So these TET spells is a group of signs and symptoms where the patient is not receiving, right, enough oxygenated blood. So you think the patient will be happy? No, of course, the tissues will not be happy. So the patient will experience irritability. The patient will experience pallor, of course, because there's not enough oxygenated blood. Number 3, the patient will experience what you call convulsions and blackouts because not a lot of that oxygenated blood is being delivered to our brain. Another, you will see that the patient naturally goes into a squatting or a knee chest position. Now, why is that? Let's take a look at this photo. If the patient is undergoing TET spells, it's not able to deliver that oxygenated blood to the rest of the body. Okay, so this is our heart. And it's delivering to the rest of the body. It has to deliver to the legs. Okay, it has to deliver to the legs, to the arms, to the abdomen, right? It has to deliver to the brain. Okay. Hence, we want to increase systemic resistance. Okay. Basically, we are cutting the circulation off here. Okay. Keeping the circulation over here. So our heart only has to deliver that oxygen over here to the abdomen. Okay. Not necessarily to the rest of the body. So we're increasing systemic vascular resistance by doing that. And that is why, their TET spells become better when they're in a squatting or a knee chest position. Our heart sound. You will hear the heart sound all over the heart. So that's what you call a pansystolic murmur. And we have 2D echo as well. So in the 2D echo, which is a kind of imaging, you will see that the heart is boot-shaped. Now, why is that? Because of this. The right ventricular hypertrophy. You will see that the patient's heart is shaped like a boot because the right side is bigger than the left side. Other signs and symptoms, the patient might have clubbing, okay, because not a lot of oxygenated blood gets to our nails. So that's also called koilonychia. Another one is the patient might also have what we call a failure to thrive. Small. Failure to feed, failure to thrive, they're having activity intolerance. So, treatment and management or action, allow the patient to squat. Okay, encourage it. Now, medication. We have what we call prostaglandin E. Which its main goal is to keep the ductus arteriosus. So if you can remember in our previous lectures, we have what we call the ductus arteriosus, which is a kind of fetal shunt. And we want to keep that open because that connects our aorta and our pulmonary artery. So what happens over here, if we trace that, again, okay, so very little pass through here. Lungs, and then through here. What happens when we have this shunt over here is this blood, this mixed, semi-oxygenated blood is able to go back instead of here into our pulmonary artery where it can be delivered to the lungs and then get reoxygenated. So that is the role of our what we call prostaglandin E. We also have palliative treatments. It's called the Blaylock Tausig surgeries. These are surgeries. Blaylock Tausig surgeries. Now, what this does, we create, we anastomose. We surgically create this shunt. So we get the subclavian artery and then we put it here. So that's the Blaylock Tausig surgery. We also have what you call curative. So kaning curative, this is called a Brock's procedure. So that's only two surgeries, basically. Two solutions. First is a balloon angioplasty. And the second is a Dacron patch. So, our balloon angioplasty, again, what is our first problem? It is the pulmonary stenosis. So if we can deliver over here a balloon, and then inflate it so that it can open up, we keep a stent here to keep it open like that. That solves our pulmonary stenosis, right? And we can also give a Dacron patch to solve this ventricular septal defect. So that normalizes the circulation already. Instead of, so the right ventricular hypertrophy will no longer be hypertrophied or enlarged if it does not have a lot of resistance to go through. And the aorta will no longer override if there is no ventricular septal defect. Do you understand that? Alright, so again, what are the 4 defects in Tetralogy of Fallot? Pulmonary stenosis, right ventricular hypertrophy, ventricular septal defect, and overriding of aorta. Is it cyanotic or acyanotic? Cyanotic. Pathognomonic sign is the TET spells. Positions, it is the squatting or knee chest. And what is our heart murmur? Our heart murmur is pansystolic. What are our treatments? Our treatments are, it can be medication, which is the prostaglandin E. And it can be surgery, na palliative, Blaylock dowsing shunt. And we also have the curative, which is the Brock's procedure. And this is all you have to remember and memorize for our, so these are your board guides. This is all you have to remember for the Tetralogy of Fallot. Okay, so again, attenuate with seizures and has a bluish skin tone, is diagnosed with Tetralogy of Fallot. Okay, so what we remember from Tetralogy of Fallot, the 4: pulmonary stenosis, ventricular septal defect, right ventricular hypertrophy, and your overriding of aorta. That it is cyanotic. That the patient has that spells squatting. Okay, what else? The patient has what you call pansystolic murmur. The patient has pansystolic murmur. Okay, and the medications and the surgery, right? Okay, which among the following theories is important? Doesn't say anything like that, right? Oxygen saturation, rather, but not necessary. The patient's already diagnosed, so you know that. Place the client in a knee chest position. Also, the notes, flashcards, summaries, quizzes, and many more are listed in the description box down below. Don't forget to join our community where we share more topics like these. Thank you and goodbye, future RNs.